Hi, my name is Angela Orozco. I'm here to present to you my patient. My patient is a 50-year-old male who was brought to the emergency department prior to the onset of um, his symptoms. He was hospitalized 3 days prior to these symptoms. He was sent home um, from the hospital. Today he presents with fever, abdominal pain, chest pain, cough, shortness of breath. So the patient was brought to the emergency department by his sister. She said he's been mildly confused since he has been home from the hospital 3 days ago. The patient states he has fever, abdominal pain, chest pain, and emesis. The onset of his symptoms were 3 days, and he states that they have progressively worsened. Past medical history includes hepatitis and IV drug abuse. He had multiple abdominal surgeries, including a left adrenalectomy, a splenectomy, a left diaphragm repair, a left anterolateral thoracotomy with repair of the left ventricle laceration and repair of the lower lobe laceration. He received transfusions in February 2015 while he was hospitalized. He has no known drug allergies. He was taking Bentyl 20 milligrams oral tablet once every 4 times a day with meals. Zofran 4 milligrams, one tablet 3 times a day PRN is needed. He has a history of his mother having diabetes. He denies alcohol, denies smoking. He does report some heroin use. Review of systems: fevers, chills, weakness, no sore throat, no nasal congestion. He is short of breath, cough, no hemoptysis, no chest pain, no palpitations, nausea, vomiting, no diarrhea, no constipation, no rectal bleeding, no dysuria, no hematuria, no discharge, no muscle pain, no bone pain, no joint pain, no back pain. This is a 50-year-old male. He appears in mild distress. He's emaciated and pale in color. The patient is awake, alert, oriented, and cooperative type 3. Vital signs 38.0, rectal, blood pressure 107/65, heart rate 137 beats per minute, respiratory rate 36 breaths per minute, O2 status 91 on room air. We placed 2 liters nasal cannula and he went up to 95%. Physical exam: head, ears, eyes, nose, throat. No, head is normal cephalic. No lacerations, no edema. Pupils are equal, round, reactive to light accommodation. 3 millimeters in size, bilateral. Conjunctiva is pink, sclera is white. No jaundice noted. Extraocular movements are intact. Ears: external auditory canal is with no evidence of CSF drainage. No bloody drainage. Bilateral tympanic membranes are intact. Nose is midline. No septal deviation. No rhinorrhea. Mouth is no lesions, no exudates. There's mucous membrane is dry. No pharyngeal erythema or exudate. There is no tenderness to the patient's neck upon palpation. No JVD. Tracheal line is midline. No masses palpated to the thyroid gland. No bruits auscultated. The bilateral lung fields are with bronchi. However, clear to cough. Patient is able to cough and clear his own secretions. There is no wheezing. He has mild shortness of breath on nasal cannula. Thoracic expansion is symmetrical. Spine appears normal, midline, no tenderness upon palpation. Sinus tachycardia to monitor. Rate and rhythm with S1, S2, no gallops, no S3s, no S4s, no murmurs. All pulses are two symmetrical, to central and peripheral locations, equal and palpable. Abdomen is flat, no distension. There's active bowel sounds to all quadrants. There's no palpable masses. The liver is not palpable. The abdomen is tender to palpation to all 4 quadrants. The male genitalia is with no lesions, no exudates, no sores, no discharge. No inguinal nodes are normal. No inguinal hernias noted. Patient has rectal tone. Bilateral upper extremities are with no edema, no clubbing. Equal pulses throughout, no cyanosis. Mental status: the patient is following commands. He opens eyes spontaneously. He is verbal and intermittent confusion to place, but overall he's a GCS 13-14. He moves all extremities with generalized weakness. 4-5 to bilateral upper extremities and lower extremities. There's no seizure activity. Cranial nerves: pupils are 2 to 3. They're round, reactive to light and accommodation. His face is symmetrical, equal facial movements. The patient has a strong coughing gave. Shoulder shrug is intact. Sensation is intact. Bulk and tone are equal to bilateral upper and lower extremities. The biceps, triceps, and patellar reflexes are 2 bilateral. Bilateral negative Babinski. Patient is cooperative. depressed, a little bit demented. Normal range of motion. Strength is 4 or 5 bilateral to upper and lower extremity skin. Scattered bruises, old scabbing. No rashes noted. White count 15.76. Red blood count 3.29. Hemoglobin 9.2. Hematocrit 27.3. Platelets 560. PT 13.1. APTT 30.8. INR 0.9. Sodium 135. Potassium 3.7. Chloride 98. CO2 28. anion gap 9. Blood glucose 102. UN 14. Creatinine 0.32. iCal 1.24. Magnesium 1.9. Phosphorus 4.0. T-Billy 0.7. HIV negative. UA was sent. EKG shows sinus tachycardia. Chest x-ray showed bilateral opacity is greater to the left side than the right. Clinical impression: SIRS, dyspnea, fever, chest pain. Assessment and plan: dyspnea. Place on O2. We're going to keep stats greater than 92. Titrate as needed. Arterial blood gas stat. Neb treatments: MDI, albuterol 90 mics per puff. 2 puffs every 4 hours. PRN times 1 dose now. We're going to follow up on the chest x-ray. SIRS, we're going to take a lactate level. We're going to give a 500 cc bolus now. The pneumonia, possible rule out pneumonia. We're going to start some Levaquin after some cultures are sent. IV 750 milligrams over 90 minutes. We're going to do some CPT. We're going to do some respiratory treatments every 4 hours. For the chest pain, we're going to give 2 milligrams of morphine times 1 now IV. We're going to do a CTA of the chest with contrast. We're going to do troponins. We're going to do CKMB. We're going to follow up on the final read of the chest x-ray. We're going to do, for the abdominal pain, we're going to do a KUB, CT of the abdomen and pelvis, and take the lipase level. For the fever, we're going to pan culture, send a complete UA, and give the antibiotics after the cultures are sent. For hepatitis, we're going to take a hepatitis paddle, PTINR, pain control, morphine, 4 milligrams IV as needed for pain of levels 6 to 8 out of 10. DVT prophylaxis, we're going to start them on the Lovenox now, 30 milligrams BID subcutaneous. SEDs to bilateral lower extremities, we're going to transfer to ICU. Differential diagnoses include flumilant sepsis syndrome, asplenic sepsis, pneumonia, UTI, SIRS, septicemia, PE, peritonitis, obstruction, pain, anxiety, and an acute MI. Thank you.